Welcome to the Croghan Foundation Early Childhood Webinar Series, Neonatal Abstinence Syndrome, Supporting Infants and Families. My name is Scott Melton. I am a continuing education planner at NAHEC, and I'll be your host for today. For the best results during this program, we ask participants to use a landline if possible, and please mute your computer speakers and microphone to prevent feedback during the presentation. Let me remind you that in order to receive credit for this session, you must be logged on a separate device with a personalized invitation sent to you by email, and you must attend the entire session to receive credit. Your credit will be tabulated and a certificate will be posted on the NAHEC MyCE area 24 hours after the conclusion of the June 7th webinar. I am mandated to report that this program was planned according to the standards of each accrediting agency, and there are no conflicts of interest. There will be a brief evaluation following the course that will pop up after the program is concluded. We ask that everyone please just take a few minutes to fill this out. There is a section on that survey for physical therapists to include their name, credentials, and license number. If you're not a physical therapist, please just type in A in the boxes and complete the evaluation. During today's webinar, you may download the presentation of the session today in the handout section of the GoToWebinar menu. Dr. Seashore also has a handout there for everyone if you'd like to see that. You can also download these later after the webinar on the MyCE area on the NAHEC website. So I'm very excited today to let you know that we have 369 professionals on the webinar today. Due to the large capacity of the webinar, we will choose and present the speaker with most of the common questions that are typed in the question box on your GoToWebinar toolbar at the end of the webinar. You may also type questions and chat to the group during the presentation. We are recording this session for educational purposes and quality assurance. This program is jointly provided by the Leo M. Croghan Foundation and the Mountain Area Health Education Center. So let's get started. Dr. Carl Seashore is our presenter today. He is a general pediatrician and the medical director of Newborn Nursery at UNC Hospital. In this role, he leads a team of talented professionals, including MDs, nurse practitioners, pediatric residents, and medical students in caring for term and late preterm infants. Over the past 9 years, he has developed expertise in the evaluation and management of infants that are at risk for and with neonatal abstinence syndrome. During this time, he has partnered with a team at University of North Carolina Horizons, a program for pregnant and parenting women with substance use disorders, leading to innovative approaches to the management of pregnant women and their newborns. Dr. Seashore has been featured on WRAL and PBS NewsHour programs to help the public understand the nuances of neonatal abstinence syndrome and its impact on families and society. And now he's with us today. So please welcome with me Dr. Carl Seashore.
Great, thank you, Scott, for the introduction and the opportunity to speak to this large and diverse group of audience members today. And I hope this platform serves as a good one for educating folks and that we can have a nice high yield session today. As Scott mentioned, I'm a pediatrician in Chapel Hill at the University of North Carolina, and I take care of babies there, including those with neonatal abstinence syndrome. So I bring very personal experience to this, having cared for lots of these babies and their families. So hopefully I can share some of that information with you all today. If you do have questions that you'd like to ask me, use the chat feature in the GoToWebinar chat box, as Scott mentioned, and he will moderate those. And at the end, I hope to have time for discussion and questions. All right, in terms of disclosures, I have no financial relationships or other conflicts of interests to disclose. I will mention some off-label use of medications in both mothers and babies, since these medications do not have specific labeling for treatment of substance use disorders during pregnancy or neonatal abstinence syndrome, despite the fact that they are the standard of care and used commonly in this setting. So the objectives of this session really are broad, and I'm going to encompass the objectives for both sessions, and I hope you'll all be able to join on June 7th for the second half of this program. But in general, I'd like everybody to be able to list the characteristics of neonatal abstinence syndrome as well as the screening methods that we use to diagnose it in newborns. And then also discuss the appropriate interventions for infants with or at risk for neonatal abstinence syndrome. And by interventions, I don't mean just medications that we use to treat NAS, but also the other really important non-pharmacologic interventions that should be part of every family's care plan in this scenario. We'll talk more in the second webinar about the core features of evidence-based treatment for women with opioid addiction, especially during pregnancy. And then we'll also talk about strategies for working with families who are facing struggles with addiction. So for background on this topic, I turn to this quote. During the past decade, narcotic addiction in the United States has reached epidemic proportions. And I think anyone who's not been living under a rock would say that that sounds like an awfully true quote for where we are today in 2018. But in fact, that was Loretta Finnegan back in 1975 when she wrote one of the cardinal papers about the neonatal abstinence syndrome. From her perspective as a pediatrician in Philadelphia, where there was a large epidemic of heroin abuse. And the neonatal abstinence syndrome was really first described in the modern literature. And so while we're certainly living in an epidemic of opioid misuse and NAS currently, we are trying to learn from history, and Dr. Finnegan and others who've studied this problem in the past, and develop a better understanding of it in the modern era, where the face of addiction looks different for a number of reasons that we'll discuss. So how do we go about thinking about treating babies with NAS and working with families who are facing addiction? And I like the old quote that it takes a village. The village that I work in is UNC Medical Center. We serve all 100 counties of the state of North Carolina, and we have about 4,000 annual deliveries each year in the Chapel Hill Medical Center. Our standard of care for all families with term and late preterm babies is rooming in mother-baby care on the postpartum unit, so our moms and babies are not separated, including those at risk for NAS, unless there's some other indication for them to have more intensive monitoring in a neonatal critical care setting. UNC is also home to the Horizons program for pregnant and parenting women with substance use disorders. And this unique program really sets the standard, the gold standard, for how to approach women with substance abuse disorders during pregnancy or while they're parenting young children. And so I'll allude today to some of the work that they do and some of the partnerships that we've formed to try to improve the care for these families. It's important, and you see the picture in the background, that our women's and children's hospitals are connected. They're the two buildings front and center there. And so it's a hallway that keeps us apart from our children's hospital and neonatal intensive care colleagues, not a transport ambulance or another barrier that might make it harder to think about how to treat for these at-risk babies. But that proximity has really given us an opportunity to work on unique models of care that have proven successful. We do have a 58-bed neonatal critical care center in addition to our busy postpartum units. And then there's a network of primary care offices throughout the region, some of which are part of UNC Healthcare and some of which are in the community. So it's a large, large team of folks that includes physicians, it includes nurse practitioners in the nursery and the NICU settings. It includes primary care doctors, but also social workers and speech therapists, physical therapists, occupational therapists, community health workers, CDSA folks, really the whole spectrum of professionals who are involved in caring for these babies. It really starts in the nursery when they're born. And so that village is what surrounds us and helps us provide high quality care to these families. So how did we get here, and where are we currently? This is a slide from the New England Journal of Medicine, a review article about the opioid crisis from several years ago. And it outlines across the bottom there from about 1999 through 2010. And you can see that the amount of opioids sold per 10,000 people, the deaths due to opioid overdose per 100,000 people, and then admissions to the hospital for opioid abuse treatment per 10,000 folks are all plotted. And you can see not surprisingly, they're all rising quite dramatically and with each other. And so the background to the NAS epidemic is really that we developed an opioid problem back in 1999 or thereabouts. And many people attribute this to the Joint Commission's inclusion of pain as a vital sign, which occurred in that year, and put more of a focus on treating pain for hospitalized patients. Others point to aggressive marketing of opioids by pharmaceutical companies, and the truth is that it's a multifactorial set of influences that have led to this epidemic. But it is undeniable that we are far and away using too much opioid medications, and too many of them have gone out of the healthcare system and into the streets, and that has spurned a resurgence in the use of heroin and other illicit substances that carry higher risks of their own. So the opioid crisis is steaming onward. It is receiving some attention, but in my view, not enough. And so the best that we can do right now, where we sit, is educate ourselves about how to interact with folks who are caught up in this opioid crisis, and provide the best care possible to them and their babies who may be impacted. If we think a little bit more down in detail about women and babies, this is a report from 2013 from the CDC, their vital signs communication, which is a public-facing communication they put out on a regular basis. And in this July 2013 release, they were highlighting prescription painkiller overdoses. And what really struck me when I read this in the middle of our trying to learn how to work better with these families and babies is that there were nearly 50,000 women who died of prescription painkiller overdoses in the decade of 1999 to 2010, and a 400% increase in deaths from painkiller overdoses among women, compared to only a 265% increase among men. And again, the reasons behind that are nuanced and complex, but the take-home message is that women, and by extension their babies, have been disproportionately impacted by this crisis. And when that moves further downstream to the newborns, this report from NIDA, from the NIH, which was authored by Stephen Patrick, who's at Vanderbilt, showed that this opioid epidemic across our country and impacting women was concomitantly causing this rise in neonatal abstinence syndrome. And so the impacts of that we'll get into in a moment here, but it's estimated that in 2012 alone, more than 21,000 babies were born with NAS, which represented a 5-fold increase from the decade prior. Translate that out to a rate, and you have every 25 minutes a baby born somewhere in the United States suffering from opioid withdrawal. And it's really important to look at the language here, especially when we're talking about newborns, but really when we're talking about anyone with a substance use disorder, that we move towards non-judgmental language, such as substance use disorder rather than addict, etc. And then also with babies, to highlight the fact that they are suffering from opioid withdrawal, but they do not have addiction. I've seen too many headlines to count at this point about addicted babies, and I cringe every time I read one. And the important thing to notice about that is that addiction includes a behavioral component of doing something despite negative repercussions or negative outcomes or risks that are associated with it. And babies are not engaging in any sort of purposeful behavior when they're born, dependent on an opiate substance from the pregnancy. They're merely biochemically dependent and perhaps withdrawing. So it's really, really important as we think about our language and talking about these patients, and especially talking with families, that we choose our words carefully and talk about dependence when we're talking about babies. So you can see on the slide there the rate of maternal opioid use in the red graph was climbing as it has been in the other graphs, and the rate of NAS, therefore not surprisingly, is climbing at a similar rate. This brings with it very long hospital stays, an average in the 2012 data of almost 17 days compared to 2 days for an otherwise healthy baby, as well as remarkable costs. Typical newborn hospitalization for birth costs about $3,500, and a baby with NAS can cost on average almost more than $65,000. So we have a crisis that's disproportionately impacting women, and as a result, babies. And so we want to think about how we can address that. Here's some additional data presented graphically and more recently showing North Carolina outcomes. So if you look at the graph on the left, you have the rates of infants identified with drug withdrawal syndrome in North Carolina hospitals per 100,000 live births. And you can see a 511% increase between 2004 and 2012, with really alarming and continuing to increase rate of NAS here in our state. And across the US, that's a similar trajectory, as you can see in the graph on the right. So what is neonatal abstinence syndrome? And if I remember correctly, Scott, we were going to have a poll here.
Yes, and I can bring that poll up for you.
Scott's going to have a poll for you in a second while we start to talk about the definition of neonatal abstinence syndrome, but feel free to go ahead on the screen as you see it to click on your poll, and we'll keep that open for a minute or so.
All right, those answers are coming in. We'll give just a few more seconds, and then we'll post the results.
Excellent participation. Thanks, folks. Okay.
So here are the results. We had 16% say that I am not familiar with caring for babies with NAS. We had 67 that says somewhat familiar. And we had 16% that said that they were very familiar. So it looks like we're having the majority of people in the somewhat familiar.
Right. So that's really helpful. It sounds like we have tails on either side of great familiarity or lack thereof, but the majority of you are in the middle. And so I'll try to tailor that that discussion to reflect that. But I'm glad to hear that most of the folks on the call at least have some, if not a great deal of experience in working with these babies. So the neonatal abstinence syndrome, or also known as the neonatal opioid withdrawal syndrome, NOWS, you'll sometimes see, is a constellation of symptoms related to biochemical withdrawal from in utero exposure to substances. And the most common substance we see this with are opioid substances. So opioids include the naturally occurring opiates derived from morphine, as well as synthetic opioids that share similar biochemical structure, but have been synthetically manufactured to act on the opioid receptors in the brain. An example of that would be fentanyl, which was developed for use in anesthesia. These symptoms really can impact a wide variety of functions in the baby, including autonomic and neurologic symptoms, so temperature instability or tremors, jitteriness or shakiness, exaggerated startle response are some. They can have sweating or clammy skin. Babies can also exhibit gastrointestinal symptoms. There are opioid receptors in the gut. And these symptoms might be difficulty with feeding or diarrhea or vomiting. So they can really present with a wide array of symptoms, And what's important to recognize when evaluating babies who are at risk for NAS, especially in the hospital setting in the first days and weeks of life, is that a lot of these symptoms overlap normal. And so when you're counseling mothers and working with families about what they might be experiencing with their baby, one of the things we tick off on our scoring rubric is whether or not the baby sneezed. All babies sneeze. Sneezing is a normal reflex response in newborns, and really what Finnegan noticed when she was outlining the syndrome in the 70s was that babies with NAS tend to sneeze excessively or more than their non-exposed counterparts. And so helping educate moms that just because the baby sneezed doesn't mean that we're facing withdrawal or that their baby is somehow sicker, but that in fact is a normal infant behavior is really important. And so helping mothers understand and helping other caretakers understand that overlap with normal of some of the features of NAS is really critical to helping them remain engaged and positive about their baby's progress, rather than focusing too much on potentially a negative perception of a symptom that could just be normal baby behavior. The syndrome can present in the first days of life and last up to several weeks, and depends quite a bit by patient. The other factors that contribute to this variability include the substances that the baby was exposed to in utero, and in some cases the dose. Although with women on medication-assisted treatment for opioid addiction, the dose does not seem to have as much of an impact as it does with illicit use of substances. The women in treatment on long-acting opioid replacements tend to have infants who present later at day 3 or 4 of life, whereas babies who are exposed to heroin in the 3rd trimester, for example, might withdraw more acutely, since heroin has a shorter half-life than the opioid replacements that we use for treatment. So the presentation can be variable. You add to that other substances the mother might be using, including most commonly nicotine, which can have its own withdrawal syndrome or potentiate more severe NAS, as well as benzodiazepines, so your Valium, Ativan, Xanax type drugs, which many women will use either in a prescribed manner for anxiety, for example, or maybe using illicitly, tends to confound the presentation of NAS or make it more severe. And there's really some emerging new understandings about the best approaches to treatment in this epidemic, in part because of the different polypharmacy that we're seeing, but also in part because of the number of women we're seeing who are in opioid dependency treatment during their pregnancy. One thing that was really not present in the epidemic of the 1970s was MAT, or medication-assisted treatment for mothers. And so the literature, the historic literature that we've based a lot of our treatment protocols on, has not really taken into account the women in treatment on a long-acting replacement. And the literature that's emerged since then suggests that those babies can have more favorable outcomes, especially if we make their treatment environment ideal after birth. So how do we think about recognizing and screening for neonatal abstinence syndrome at the time of birth in the hospital? It's obviously of critical importance to have a complete maternal history, including her past medical history, but also the obstetric history for previous and current pregnancy, as well as what her prenatal care consisted of. In the current epidemic of heroin becoming a drug of choice again, as it's been become cheaper than the prescription pills that many women start their opioid problem with. The rise of hepatitis C infections in these women has been astronomical, and so that puts the infants at unique risk of vertical transmission of hepatitis C as one example. So you just want to make sure that you have all those details and understand whatever comorbidities or other risks there might be related to mom's history or something that occurred during the pregnancy. What we do know is that a lack of prenatal care is associated with higher risks of preterm delivery, which is a far more severe outcome than neonatal abstinence syndrome. And so getting these women into prenatal care so that they can have a term baby is much preferred to the alternatives. We use targeted drug screening of both mother and baby in labor and delivery. And there's some evidence in areas of epidemic opioid use that universal screening, toxicology screening of mother and baby leads to improved outcomes. So you'll see variability in practice depending on where you are as to how frequently and in what manner drug screening is used. But ideally, the screening occurs in both mother and baby, and the results are obtained with confirmatory testing, and the screening results are not utilized for decision making. So if you had a positive screening test as part of the baby's hospital admission, you'd want to assure that there was follow-up confirmatory testing that the substance was indeed present. We then move on to symptom recognition in the newborn. And so what I alluded to earlier is the baby difficult to console, more jittery, or more exaggerated with their neurologic responses. Is the infant having a hard time coordinating sucking and swallowing, or having excessive watery stools? Is there a lot of sweating, etc.? In order to make this structured, it's recommended that infants be assessed using some sort of structured tool. The Finnegan or the so-called modified Finnegan assessment tool is still the most commonly used approach, and that approach measures about 25 discrete symptoms and assigns a score of 1, 2, or 3, and then those scores are added up to determine the severity of NAS, and the treatment decisions are informed at least by those scores. There's some emerging tools that focus on more functional outcomes of the babies, and so the ability to eat, the ability to sleep, and the ability to be consoled are given greater focus, and less attention is paid to, say, sneezing, as I was alluding to earlier. And so it's less important which of these tools is being used in your hospital or the hospital where the patients you care for were seen. What's most important is that a tool is used and something is used consistently so that the management of these kids meets that minimal standard of care. And lastly, one thing that I found to be critically important in working with this population is teamwork. And this isn't unique to neonatal abstinence syndrome or newborn care in general, for sure, but I think it's uniquely challenging in the setting of having so many different people involved with, at the end of the day, 2 patients, the mother and the baby. And so the complexity of that communication is greater than it is in some other settings. And so really making sure that for the mother's care, your obstetrics, midwifery, family medicine, addiction specialists, anesthesia are all working together to come up, for example, with a pain management plan that's going to be informed by a woman's opioid use disorder in terms of what medications are the best approach for her. And then on the pediatric side, you might have a whole host of folks involved in that baby's care, and of course working alongside with social work and other folks in the hospital is really important. We frequently have our speech pathologists up to see these babies and work on feeding. Our lactation group works very closely with these moms when they're breastfeeding. And our social workers are intimately involved in discharge planning and ensuring that is happening in a safe manner. So it's a multifactorial approach we take to recognition and screening. And one thing I wanted to highlight about the approach we've found to be very successful at UNC is our involvement of the mothers in that process. So in addition to your multidisciplinary healthcare provider team and medical teams, you have to include the mother as part of her baby's treatment team. And so we developed this brochure, which I'll share with you over the next 2 slides, and it's included in the handouts. And you're welcome to take it and modify it for your own use as it would be helpful. But this is something we will share with the mothers during a prenatal evaluation when they're known to be on opiates for some reason, whether that's prescribed for pain or for opiate use disorder, and they're on medication-assisted treatment. But we really try to give them a sense of what to expect over the first several days after their baby is born, what will happen in the hospital, and then what the potential treatment paths are, including medication for the baby. But also before that, what non-pharmacologic interventions they can be doing from the very beginning to optimize their own infant's outcome and progress after birth. And so this is a little trifold thing, and this is the sort of front side and the inside, if you will. But this describes in lay terms that a mother can understand what neonatal abstinence syndrome is, lots of which we've talked about, what the symptoms she might see in her baby, and how those may develop over the first several days of life, or even into the first few weeks, and then how we think about assessing those babies and involving them in that care. So after we had success with this maternal engagement using our brochure, we moved further to develop this parent scoring tool, which if you get past the blandness of it on a slide and imagine it's a laminated piece of paper and you have a dry erase marker and you're the mom taking care of your new baby, you can just simply make little notes on this that you can then share with your nurse and say, oh, he was, really slept well this time, or I only noticed mild tremors, and really it was only when I was changing his diaper, or gosh, he had a really loose watery stool, or no, his last stool was nice, or meconium still, or whatever. But this provides an instant feedback mechanism for the mother to be engaged in her baby's care and understand some of the things that her baby may be doing that could represent withdrawal. And then on the flip side, it allows the nurse to say, oh yeah, sneezing. He just sneezed 1 or 2 times. That's no big deal. Don't you worry about the sneezing. Let's focus on how baby's feeding. And so it prompts a dialogue between the mother and the nurse or the physician or the midwife or whoever's taking care of the baby to engage her in the care of the infant, as opposed to making her feel judged when her baby is being assessed by the nurse and perhaps has some of these symptoms, that those symptoms are somehow her fault, which is really not the case, because she was in most cases adhering to the recommended treatment plan for her baby. So involvement of mothers on the care team has been a really critical aspect of our recent success with managing babies at UNC. And I think it's something that translates to many of you who work in the outpatient realm and are following these babies who are weeks or months or even years older, with whatever challenges they may be facing down the road, to consider how you're involving the mother and the other caretakers in the baby's treatment, and what sort of language we're using to talk about NAS and the impacts of NAS, and the symptoms or other manifestations of it that help them feel empowered and engaged as a parent, as opposed to judged or threatened in their role of caring for their baby. So as far as what the medical team and the hospital team then continues to do for care of the opioid-exposed newborn, again, a lot of emphasis on maternal engagement and involvement in the treatment plan. This begins prenatally and continues through discharge and beyond for us. The rooming in care, just like you would do for a non-exposed baby, has been shown in several studies, including some in Canada as well as here in the United States at multiple sites, that without a different indication for NICU admission, keeping the NAS risk baby and its mother together improves treatment rates for NAS length of stay, and possibly also breastfeeding outcomes. Employing a standard and structured approach to the application of both non-pharmacologic interventions is really key. And so thinking about swaddling as medicine, thinking about turning the lights down as medicine, thinking about turning the TV off as medicine, thinking about limiting the number of visitors in the room as medicine, thinking about skin to skin and breastfeeding with the mother as medicine, are all things that, again, can empower that mother to make choices for what's going on in her room and with her baby, to improve and optimize the outcome. And so if you have a baby who, for example, is seeming a little bit hard to console and jittery, then swaddling that infant and doing some things that you might do to soothe any fussy baby are a really important first step, as opposed to aggravating the baby and making those symptoms worse. You want to have a standardized approach to newborn assessment. Like I said, the Finnegan scale is the most common one. The recently published what's called the ESC score out of Yale is showing a lot of promise, and folks are beginning to use that in other places. So I think the literature should give us some good guidance on the validity of that eat, sleep, console approach that I mentioned earlier. But having a standardized approach is key. And then we do use medications for treatment of withdrawal symptoms that are severe or are interfering with those basic newborn functions of eating, sleeping, and being able to be consoled. And so if you have a baby who is clearly not feeding well, is losing weight, is having copious diarrhea, is hard to console, is scratching its face up with its little fingernails, and uncomfortable and miserable, that's obviously a baby who's going to benefit from a short course of medications. But if you have a baby who tallies up on their scorecard a bunch of minor symptoms and reaches a threshold of potentially intervening, that may not be the best approach. Again, this is something that's really in evolution, and there's a nice review of this with the link to the article at the bottom if anyone wants to read further about that. In terms of medications that are used, the most common is morphine, because it has a short half-life and can be given relatively easily in small doses. Other medications that are often used are methadone, especially when that was the mother's medication during pregnancy, or if there's a plan for discharge. So some of you working in the communities may have babies who are discharged from the hospital on a methadone taper. And that's been shown to be effective, although there's no long-term studies comparing outcomes of long tapers of methadone compared with morphine treatment in a hospital setting. Phenobarbital is historically used, but it's not as common today, although there was a recent paper out of Tennessee showing some long-term follow-up discharge plans involving phenobarbital that was a bit concerning. So that may be something that you also see. And then lastly, clonidine is another medication that's sometimes used, often as a second-line agent if the withdrawal is particularly severe. The typical course of a medication treatment for a hospitalized infant is, again, several weeks. And with an outpatient taper of something like methadone, it may last even a couple of months. Non-pharmacologic treatments, as I mentioned, should really be administered in a structured and prescribed pattern. Rooming in is the one that has the most evidence to support it. Breastfeeding is also recommended as a treatment for NAS in the mother who is stable in treatment and doesn't have another contraindication to breastfeeding, such as HIV infection. And so if you don't have a contraindication to breastfeeding, those babies have better outcomes, and I'll show more on that in the next slide. The baby's environment is really important, and I think a lot of what we see rooming in contributing to improvements with is exactly that. The baby being with its mother is really the best medicine, and merely by admitting the baby to a neonatal intensive care unit, you're separating the mother and baby in many circumstances, and that in and of itself is stressful and can potentiate symptoms of withdrawal. But further than that, keeping the environment quiet, peaceful. We have some swings that we use. We'll play some lullaby type music in the background. We'll keep the TV off and the visitors limited so that it's a really peaceful and calm and not overstimulating environment for these babies. And then if they are in the NICU, either for NAS or for other reasons, what can you do in that environment to make it ideal or at least optimize it? for the babies. And so looking at that for those of you who work in hospital settings and see these babies in NICUs, what could you do to do that? And many hospitals around the state have moved to private room NICUs where the mother and the baby do stay together, but the baby's able to receive a higher level of care. But it's important to think about those things, to actively survey the environment and do what you can to minimize that overstimulation. And again, engaging the mom and whichever caretaker she brings into the fold, or whichever caretakers come into the fold if the mother is not there, and educating them about ways to decrease stimulation for the baby and make that environment supportive and peaceful are all shown to be beneficial and decrease the length of stay and the use of medication to treat withdrawal. So non-pharmacologic treatments are the standard of care. That's been true since Finnegan's paper, skin to skin, breastfeeding without illicit use. One of my favorite things to do in the nursery is teach parents how to swaddle, and I've been thanked years later by folks who see me in the hallway of the hospital and say, "Oh my gosh, swaddling the baby was the best thing. Thanks for teaching me." So any of you who work with newborns where swaddling is still appropriate, it's a great skill to share if you're great at it and notice that a parent isn't. And then minimizing those external stimuli. Here's a table from a 2006 paper in the journal Pediatrics looking at breastfeeding outcomes specifically, and in the highlighted column there you can see that in the breast milk fed group, treatment for NAS, pharmacologic treatment for NAS was only needed in 53% of babies, whereas the formula group, it was 80%. That was statistically significant. So this isn't just a theoretical outcome, it's a proven outcome, and it's important to recognize that it's likely not due to transfer of medication in the mother's milk because those levels are actually quite low, but it's likely related to the process and the physiology of breastfeeding and the bonding and the closeness that occurs for both the mother and the baby when they have that relationship. Pharmacologic treatments I mentioned, they really should be considered second line if your non-pharmacologic interventions are not working. And again, that's the list of agents you may see. The one on there that I did not mention is buprenorphine, which is commonly used for medication-assisted treatment in mothers, and does have one study that was published showing that it's potentially better and at least as effective as methadone or morphine. And so especially in moms who may have been treated with buprenorphine, you may see that as an agent that the babies are being treated with for NAS. So referral and long-term follow-up, I think, is where many of you all in the audience today live. And so you all could, I'm sure, teach me more about this than I can you. But the standards that we adhere to in our hospital is that social work is consulted for all families in a supportive manner. We make a CC4C referral for each of these families as part of their discharge plan to ensure that community follow-up is in place and early intervention is begun from the beginning. Many of you, I'm sure, have heard about the plan of safe care, which is related to the CAPTA or CARA legislation federally, and North Carolina's plan for that is outlined in the handout, but that would be a whole nother talk to dive into the weeds of that. I think for this talk, it's important to notice that it exists, and there's excellent resources available from the state of what it looks like, and that it's not a punitive referral, as many referrals to Child and Family Services are perceived, especially by families. It's a supportive referral to ensure that that infant is going home to a safe environment. If you see infants from other states, it's also important to know that different states have different requirements, and those with harsher requirements, I'm sure some of you have seen, cause their babies to come to North Carolina to be born because their neighboring state has tougher or less supportive rules in place. And then ongoing support for mom's treatment, and we'll delve into that a lot more in the second part of this webinar in a few weeks. But all of those are really key during the birth hospitalization as part of the discharge planning, so that the mother-baby dyad can go home together on a path towards success. In terms of outcomes, less is known about this than needs to be, but the most important health outcome that I think I take away from thinking about NAS is that NAS is an expected and manageable outcome of pregnancy in a woman on opioid replacement therapy for a substance use disorder. And compared to her not being in treatment and continuing to have perhaps relapses of drug abuse, or perhaps not seeking prenatal care for fear of the repercussions of that, her likelihood of having a premature infant goes way, way up, and the complications of prematurity we know are far more severe than the complications of NAS, including a higher mortality rate. And so I will take a mom on buprenorphine in opioid treatment program all day long over a woman who has been engaging in illicit and erratic use of different substances through pregnancy. Beyond the newborn period where we see NAS, there are some conflicting observational and retrospective studies that have been done showing some developmental delay along a different spectrum, including cognition and language scores. That particular paper was looking at just 12-month follow-up. Different eye and visual problems have been shown, including some strabismus and amblyopia. Hepatitis C exposure is obviously very real. There's an interesting study from the Netherlands, and these references are all in the bottom of the screen. You can click through for further reading if this is of interest to you, that medical neglect and non-accidental trauma are more common in babies who had experienced NAS during their birth hospitalization. And then there's conflicting data on whether ADHD or other attention problems are increased at school age in this population of kids, and that's something that we're looking to study currently. What's important in thinking about the long-term outcomes in these kids is that it's impossible to control for the home and environmental exposures after birth, and it would be unethical to do a randomized controlled trial where some women got treatment and others didn't, and you looked at how their children did 5 years later. And so, again, much like the pregnancy where treatment and MAT is happening along with prenatal care versus not, I would much rather see this child who had NAS as an infant being raised in a supportive home with a mother who has successfully been in treatment and is stable, who is providing a more consistent home environment for that child, whose involvement with the CC4C program and early intervention and then preschool has set that child up for success when they do reach school age, by interrupting the chaotic environment where addiction continues in the home. There's a suite of tools, and again, these are available in the handout that we use with our mothers as their babies grow, including a parenting program called Circle of Security, another specific nurturing program that's substance abuse specific, a really neat program called Hug Your Baby about the importance of skin to skin in the early days. And then all of these families in the Horizons program get child-parent psychotherapy, a dyad of psychotherapy where both mother and baby are observed and counseled together, and their interactions observed, and then coaching is done for the mother to help her adapt to the baby's temperament and things of that nature. So these tools are all available for download at the links provided. And what this translates to are some really impressive outcomes with the Horizons program. And I share this as a parting slide, and then we'll have 10 minutes or so for discussion. But looking at the 2016-2017 outcomes with the Horizons program, 266 women received treatment here in Chapel Hill, and 77% of the graduates had a job at the time of graduation. So they weren't just in remission from their substance use disorder, they were employed, and that's part of the program at Horizons that we'll touch on next time. 100% had improved or stable child protective services outcomes, so they retained custody of their children. And 64 healthy babies were born to these women who came to term, and whether or not they had mild NAS, but they had remarkable newborn stays, and were able to go home with their moms and continue in the family-oriented treatment program that's offered. If we stretch that around the country and around the world, based on the outreach that Horizons does, and I hope some of you have received some of that here in North Carolina, nearly 5,000 folks have been impacted. So really important work, really gratifying and fulfilling and meaningful work, and impactful as well. So that's, I believe, the end of my prepared remarks. And Scott has a follow-up polling question for you. And with that, I will turn it over to Scott to moderate any questions.
Sure, let's go ahead and do that poll right now. So I'm going to go ahead and launch it. It just says, what percentage of increased knowledge about NAS have you gained from this webinar today? I'm going to give you guys just a few seconds to go ahead and log those in. We see there's numbers coming in, and then we've got some questions for you, Dr. Seashore, that I've been able to gather from the group. We'd love for you to be able to help us understand some of those things. Got about 70% that's voted in. They're still coming in. Just a few more moments while everybody gets in their poll. We've got about 83% in. Awesome. And again, that question was, what percentage of increased knowledge about NAS have you gained from this webinar today? And I'm going to go ahead and close that out. And I'm going to just share today, and we'll just see how we're doing. We see that there's about 20% says they've had a 25% increase. We've had 33% say a 50% increase. We've had 40% say that they've had 75% increase. We've had 8% say that they've had 100% increase. So that is fantastic. I'd like to thank everyone for participating in that poll. So the first question that we have, Dr. Seashore, is from Michelle. A lot of the agencies that are attending today are dealing with mothers that are breastfeeding. And they were just asking, could you clarify just a little bit about children potentially having withdrawal symptoms later after they leave the hospital when the mothers are breastfeeding, or if the mother stops? Is there any insight that you can give us on that?
That's a great question, and I appreciate you asking it, because you're often interacting with these families weeks or months down the road, and breastfeeding, as we know, is something that doesn't go on forever. And so in the studies that have been done on this, what we know is that relatively low levels of medication are excreted into breast milk. And so the baby's effective dose of an agent like methadone or buprenorphine that the mother is taking for MAT is very, very low. And so if she is, say, 100% breastfeeding at hospital discharge, but down to 50% breastfeeding at a month or two of life, and stops breastfeeding altogether at 3 or 4 months of life, there would not be enough of a physiologic withdrawal in that time frame from a medication perspective that it would exacerbate the child's withdrawal. Now, could there be some manifestations of withdrawal-like symptoms if the baby is missing that contact, or if the breastfeeding relationship was stressful between the mother and the baby? I think those could sort of get conflated in there, but from a physiologic perspective, with opioid replacement therapy, women in treatment, the effective dose that gets to the baby is very low. If you contrast that to substances that aren't being used as a means of treatment, for example, a mother who went and snorted cocaine while she was breastfeeding, that drug goes into breast milk at pretty high levels, and the impact on the baby can be dramatic. And so it's important, as you think about that question and its relationship to your patients, is if it's a mother who's in treatment on a stable dose of an opioid replacement agent, then NAS or impact from exposure shouldn't be a concern. But if you have someone who has relapsed and been using substances illicitly, then you could see manifestations in the newborn from that type of exposure. I hope that clarifies.
It does, and Andrea had asked a question for about how long, would you recommend that women breastfeed and when should they discontinue breastfeeding?
Yeah, so as long as they've remained stable, and if they're continuing on MAT, medication-assisted treatment, which is typically going to be methadone or buprenorphine, Suboxone, then as long as they mutually desire is the textbook language for that. So as long as the mother and the baby want to continue breastfeeding, AAP recommends it exclusively for the first 6 months of life, and then through the first year with complementary feeding. The World Health Organization recommends through age 2. Granted, they're looking at a global audience, not just the United States. But certainly I wouldn't shorten that recommendation for a woman with treatment unless she fell into a relapse and was potentially exposing her baby to other substances, like cocaine, as I mentioned, or something else that might harm the baby. It's a great question.
Thank you. We have one more. Leslie was asking, there seems to be a lot of similarities in the symptoms in opioid-exposed infants and infants born premature, as well as some of the non-pharmacological care. For a premature infant, how does that affect their score on the modified Finnegan, as well as determining the treatment for the NAS premature infant?
That's a great question, and I'll put a caveat to my response, which is that I'm not a neonatologist by training, so I've taken care of some premature infants, and certainly late preterm infants, plenty, but very premature infants. My experience dates back 20 years now. But from the literature, again, what we know with prematurity is that the manifestation of NAS actually seems to be less in the very premature infants, something about their neurologic development at 26, 28, 30 weeks. Changes what we think of as NAS in a term baby, and we don't see those typical symptoms that Finnegan described in the 70s. But you see all the complications of being 26 weeks or 28 weeks, which are not trivial. In the late preterm infants, I found myself having to be careful with things like respiratory symptoms in say a 35 or 36 weeker. Who's at risk for NAS, just because the things that late preterm infants can do related to respiratory distress or their risk for infection are different than with a term baby. So I approach that population with a little bit more caution, and am less quick to attribute a symptom simply to withdrawal, as opposed to some other manifestation of their shorter gestational term. And so if I have a child, for example, who's having respiratory symptoms and they're 35 weeks or 36 weeks, I'm quicker to get an x-ray and start evaluating their respiratory symptoms. Whereas if it's a 39-weeker and it's kind of classic hyperventilating of NAS, then I'm less concerned. But the late preterm infants are probably the hardest bunch in there, because they can fool you into thinking that it's just NAS when in fact they might be harboring an infection or something else potentially more serious. And so I do approach that population with an abundance of caution compared to the term population.
Fantastic, thank you. I think we have time for one more question, and saw this one. I just thought it was an excellent question by Eugene. It says, how might NAS impact children as they become toddlers and preschoolers, and what kind of symptoms are there to let us know that that's what we're seeing?
Yeah, and I tried to sum that up, what little is known about it, in one of the last slides there. And I don't know if that's still showing.
It is.
So what we see with longer term follow-up is certainly some mild developmental delays, and in Bailey assessments, for example, they're a little bit behind their non-exposed peers. The eye complaints are a little bit more frequent, and so when you're seeing, say, an 18-month-old or a 2-year-old having a lower threshold to get their eyes evaluated by an ophthalmologist is a very reasonable path to take. It's really important to follow up that hepatitis C exposure around 18 months to 2 years of life. And then that risk of medical neglect and non-accidental trauma is really important to understand. And what I hope to have relayed is that if we're successful in engaging the mother in treatment beginning in the prenatal period and continuing postpartum, then that's the sort of impact I think we can have the biggest effect on, where a mother who is stable with her addiction, no longer engaging in those risky behaviors to herself which impact her child, and as with the Horizons graduates, perhaps employed and out there living in the community, those risks theoretically should go down. Again, that's a very difficult question to study in a rigorous manner, but breaking that intergenerational cycle of addiction and abuse in the home and such, I think would allow us to have a bigger impact in the long run. And then later on in the school age kids, ADD and other attention problems, it's really hard to tease that out, looking at the NAS experience around birth versus what happened in the subsequent 5 years of life before they walked into kindergarten. And so that's an area that I think future study will really be helpful for. But these are things that we'll talk about on the June 7th webinar. So great questions to set us up for next time.
Thank you so much, Dr. Seashore. That was amazing, so helpful. So I would like to thank everybody for attending today. Please remember to wait until the webinar closes and fill out the brief 5-question survey. This information will be used to help us with making our next session on June the 7th even better. So please, I would like to remind the PTs and PTAs that they must provide their name, credentials, and license number to receive credit for the course on question number 5. Everyone else can just type NA in that box and complete the evaluation. Thanks again. We'll see everybody on June the 7th.
Thank you all.